So hello, colleagues and friends from different parts of the world. Welcome to this webinar organized by the Voice Committee of the International Association of Communication Sciences and Disorders, the IALP. I am Estella Ma, chairperson of the IALP Voice Committee, and it is my great pleasure and my great honor to be the moderator of this webinar today. Allow me to take this opportunity to introduce the Voice Committee to the audience. The Voice Committee has 12 members, consisted of 2 expert consultants and 10 committee members, and we come from a wide geographical regions and covering a wide range of expertise areas in voice. As the Voice Committee of the IALP, we are committed to facilitate better understanding, knowledge, and care for all individuals with voice disorders. And the committee provides a platform for international networking, advocacy, and knowledge sharing. And we believe that close communication with our members and the community is the key to achieve our mission. So apart from this webinar, the committee issues publications such as newsletter and the IALP Insights on Voice and Voice Disorders. These are the resources for the community as well as for our members. And also with the leadership of our former chairperson, Dr. Debbie Phelan, the Voice Committee developed an educational video called The Working Voice to raise the global awareness about vocal health and also the important role of our voice plays in everyday professional as well as personal life. And I also want to invite you all to watch the featuring video in cooperation with the World Health Organization. This video is titled Jamie Lee Journey Through Vocal Rehab. It is a powerful video documenting the journey of Jamie Lee Hankerson, who is a fabulous musical theater performer going through the vocal rehabilitation. And here on this slide, you can find the QR code to access to these videos. And please do access the videos after this webinar. Apart from that, please also do follow the IALP on LinkedIn page for more upcoming activities and also resources sharing. Now, a few housekeeping issues before we get started. First, please note that this webinar is being recorded, and later on this webinar will be uploaded to the YouTube video, to the YouTube channel of the IALP. And if you have any questions, please type your questions in the Zoom chat box. The speakers will address the questions in later on the panel discussion session. And if you require an attendance of certificate, please leave your name, your surname, in an email address in the chat box as well. The topic of today's webinar is Unlocking Clinical Voice Care from Physiology to Clinical Practice. Through this webinar, we will hear about the working principles of voice care strategies, scientific evidence, and also advancement in voice care strategies. And we have 3 wonderful, very delighting speakers today. All of them are committee members of the Voice Committee, and I have the privilege to introduce them, and I'll introduce the speakers in the order of the talk. Our first speaker is Dr. Preeti Sivasanka from Purdue University in the United States. Preeti is the Vice President for Research Innovation at Purdue University in the US. She's also the Adjunct Professor of Otolaryngology of Indiana University School of Medicine in the US. She's a fellow of the American Speech, Language, and Hearing Association, ASHA, as well as Associate Fellow of the American Laryngological Association, ALA. She's also the past editor of the American Journal of Speech Language Pathologies. For her main areas of research interest, her research program focuses on the voice and upper airway pathophysiology, and her research is funded by the National Institutes of Health. She's going to talk on tonight on hydration for vocal health, fact or fiction. Our second speaker is Maria Dietrich. Maria is also the committee deputy chair of the Voice Committee. She is the research associate in the Department of Psychiatry and Psychotherapy at the University of Bonn, University Hospital Bonn in Germany. She is the director of Specialty Outpatient Clinic for Functional Voice, Speech and Swallowing Disorders and the Vocal Control and Vocal Well-Being Lab, Vocal Well Lab. She's also the adjunct associate professor at the University of Missouri and also the University of Memphis in the US. Her main areas of interest include how individuals differ in the vocal control and vocal behavior due to stressor, exposure, and personality. And her research aims to improve the biopsychosocial models of risk for voice disorders using psychophysiological and also neuroimaging methods. And tonight, she'll share with us the talk on the chronic cough conundrum, the role of the voice therapist. Last but not least, we have Dr. Anna White. And Anna is the clinical academic speech and language therapist at Nottingham University Hospital NHS Trust in the United Kingdom. She is the National Clinical Advisor for Voice Disorders for the Royal College of Speech and Language Therapists, and she's also an RCSLT research champion. Her research and also clinical interests including improving voice outcome for patients with voice disorders, pre- and post-operative voice therapy for benign vocal fold lesions, the development and evaluation of complex interventions, as well as investigating behavioral change techniques within the field of voice therapy. And tonight, she will share with us on the talk, Silent Reflux, Loud Consequences, Understanding the Impact of Laryngopharyngeal Reflux on Voice. So at the end of this session, of this webinar, we hope that participants will be able to understand the basic mechanism of vocal fold hydration as well as dehydration. Secondly, be able to describe treatment strategies with patients with chronic cough. And finally, understand the potential impact of laryngopharyngeal reflux on vocal health, and also consider the role of SLP in supporting patients with suspected LPR. Now, without further ado, let me hand over the floor to our first speaker, Dr. Preeti Sivasanka, for her talk. Preeti, please.
Thank you, Estella, for that wonderful introduction. Hello, everyone, and thank you for making the time to attend this webinar. I will be talking about hydration and what we understand about hydration in supporting vocal health. I will be presenting data over the next 10 minutes. So I'm hoping that at the end of this presentation, you can decide whether hydration for vocal health is fact or fiction. And my apologies in advance. I'm recovering from a cold and cough, so I may need to mute myself periodically. But let's get started. So we are all here because we have an interest in understanding more about voice disorders and the pathophysiology of voice, because we care about better prevention and optimal treatment for voice disorders. So let's begin by contextualizing the importance of understanding voice disorders better. So we, of course, know that voice disorders are common. They manifest across geographical locations. We all see individuals with voice disorders. When we look at statistics in the United States alone, 1 in every 13 Americans, adults, report voice problems. We know that voice disorders reduce quality of life and they impose significant social and economic burden, as seen by lost work days, the costs of healthcare leaves, for example, in order to recover the voice, and so on and so forth. Now, we know that the primary cause of voice disorders is actually the mechanical trauma that's induced when the vocal folds are oscillating. And this is especially apparent when the vocal folds are engaging in large amplitude and sustained vocal fold oscillation, because this results in high contact pressure. So it's no surprise then that individuals who use their voices with loud voice use and for continued and sustained voicing are more likely to report voice problems, such as occupational voice users. So a lot of attention is then focused on how we can support vocal health and healthy phonation in order to prevent voice disorders from manifesting in the first place. And this is where we think about whether hydration has a role in supporting vocal health and keeping the vocal fold tissue robust and healthy to support the prevention of voice disorders. So what do we know about dehydration and the larynx? Well, there have been over 100 studies that have really looked at the role of hydration and dehydration in laryngeal physiology, biomechanics, and voice production. And interest in this area really peaked in the early 2000s and has spanned several decades of work. And what we know from studies that have directly manipulated dehydration is that dehydration can change the biomechanical properties of vocal fold tissue. But these are studies of direct dehydration. So in other words, the larynx is placed on a benchtop and is exposed to a dehydrating stimulus. But this type of direct dehydration does not really mimic what is happening in the body when the structure is in homeostasis or a state of comfort and physiological resources. And that's more like an indirect dehydration, when you actually have strong vasculature and lymphatic support in order to keep the system in homeostasis. And when we think about more of this indirect dehydration, so in other words, when we think about in vivo studies that are done in a subject, we find that the data on dehydration is a little mixed. So while there have been studies that have shown that dehydration can make acoustic measures worse, that it can hamper aerodynamic parameters, that it alters vocal fold kinematics negatively, these data are mixed, and not every study is robustly showing a clinically meaningful difference. So what is still really unclear is how and why dehydration may change the voice. Because what we know is that when we drink water, it doesn't really reach the larynx, right? The water we drink just crosses the upper airway into the aerodigestive tract. So the question really is, what is the mechanism? How and why does hydration influence the larynx? So when we think about the why and how, my research lab has for several years been focused on understanding the underlying biology that predicates the role of dehydration and hydration and laryngeal pathophysiology. And we've asked some fairly fundamental questions, such as, when the body gets dehydrated, do the vocal folds get dehydrated? Because when you think about our body in homeostasis and you think about all the organs that have to function efficiently and in synchrony, at what level do the vocal folds get dehydrated? We have asked, if the vocal folds get dehydrated, are there adverse effects both in the biology and in vocal fold function? And we've also asked whether these effects depend on the mode of dehydration. So does it matter if someone is on medication? If someone is dehydrated because they have reduced water intake? What happens if someone is fasting and has no water intake that they are participating in? If indeed vocal fold biology is adversely affected by dehydration, we have asked whether rehydration can reverse or mitigate these negative effects. And we've also asked questions about the interaction of underlying conditions with vocal fold dehydration. So what about aging, chronic disease, hormonal changes? Do they increase the negative effects of dehydration? So let me start showing you some data. And in the next few slides, I will show you kind of the bottom line of some of our studies. But on each of these slides, you will see the reference indicated, and I encourage you to go back to the source to get more data about how the study was run. So, in answer to the first question, do the vocal folds get dehydrated? We used a technique called proton density weighted MRI, which can quantify the amount of water in tissue and relate that to signal intensity on MRI. And what we found was that when the body gets dehydrated because water is restricted, the vocal folds indeed do get dehydrated. And we saw that these vocal folds have lower signal intensity, suggesting that there is dehydration. We also found that recovery from dehydration depends on the magnitude of the dehydrating event. So when the vocal folds are very significantly dehydrated, it takes much longer for them to get rehydrated than when the dehydration was of a small magnitude. So this is interesting from a clinical lens when you think about dehydrating conditions that we may be exposed to. We found that when the tissue is dehydrated, the biggest change is to the epithelium of the vocal folds. As a reminder, the epithelium is the outermost layer of the vocal fold tissue, and it's a really important type of cell because it serves as a barrier. It's a barrier that protects the inside of the vocal fold from pollutants or pathogens in the airstream, and it also prevents stuff from inside the vocal fold from leaving and extruding out. And we found that dehydration can actually affect the integrity of this epithelial barrier. It can make it more leaky, thereby changing the gating function that the epithelium has. We found that medicines do indeed dehydrate the vocal folds, and we specifically looked at a diuretic called furosemide. And we found that furosemide can actually alter the architecture of the vocal fold tissue, and it can also affect this epithelial structure that I discussed in the previous slide. We found that superficial dehydration, as demonstrated by exposure to low humidity, is also detrimental to vocal function. And we found that low humidity exposure can actually increase cellular stress in vocal fold tissue. And that when actually the low humidity exposures are more chronic or repeatable, that these detrimental effects increase and are seen not only by a change in increased cellular stress, but also a change in the muscle structure and function of vocal fold tissue. We have found that rehydration can help reverse these dehydrating effects, but again, we have found that the effects of rehydration really depend on how much dehydration manifested initially. So rehydration can only do that much. The ideal goal is to reduce the magnitude of dehydration. And then we found that underlying conditions can make the vocal folds more vulnerable or susceptible to dehydration. So conditions we have examined are aging vocal folds. We found that older vocal folds are more susceptible to these negative biological effects of dehydration. And we found that dehydration can also slow the process of vocal fold healing after injury. So basically, I showed you lots of data. And again, I encourage you to go back to the initial reference to learn a little more about the methodologies we have incorporated in these studies. But hopefully, through many of those data sets, what I have made a case for is that dehydration does cause negative biological changes to vocal fold tissue. So conversely, what we can interpret these data to suggest is that hydration does support vocal fold health. But where we still lack a lot of scientific consensus is how much hydration is needed in order to improve and maintain healthy vocal folds. And actually, what we know is that there really is no scientific consensus on the amount of water. So the typical recommendation to drink 8 glasses of water a day has really not been scientifically verified or confirmed. So instead, I encourage all of us to think about hydration, not only from the lens of drinking water and fluids, but from an optimal dietary intake. So what we have to recognize is that water is not the only source of hydration. Hydration comes from a variety of dietary sources. And therefore, when we are engaging with patients and thinking about hydration, not as a cause of voice disorder or as a treatment for voice disorder, but rather as an adjunct to support robust vocal fold health, that we encourage our patients to be thinking more broadly about dietary sources of hydration. So I'll end by saying there really is no universal recommendation for the amount of optimal water intake for optimal vocal fold health. Our consideration of how much water to drink is really driven by thirst and by understanding of the underlying medical condition. Now, we know that some medical conditions can affect the perception of thirst, and therefore it's really important that our patients consult with their medical physician before identifying how much water to consume in order to maintain vocal fold health. So with that, I'll just really quickly acknowledge members of my research group who for many, many years have studied vocal fold dehydration from a very programmatic lens. And thank you all for your time, and we welcome questions over the panel session. Thank you.
Thank you, Preeti. It's a very interesting talk, and keeping good hydration is always among those top 3 recommendations that we offer for our clients, for the community, for general public on vocal health. So really good to listen to those scientific evidence behind these recommendations. Thank you. So let me invite our second speaker, Dr. Maria Dietrich, and share the talk on cough.
Good morning, everyone. Good afternoon, good evening. I will be talking about chronic cough conundrum, the role of the voice therapist. I want to start with my disclosures. Essentially, I want to point out a non-financial disclosure that I'm a founding member of the Functional Neurological Disorders Society and also a founding member of the German Functional Neurological Disorder Society. So what about the prevalence and incidence of chronic cough? So chronic cough, by definition, is cough that lasts longer than 8 weeks. The estimated prevalence worldwide is up to 10%. The estimated 12-month prevalence in Europe is, for example, 5%, and it is more frequent in the aging population. So of this pool of people with chronic cough, there's a subgroup of people with refractory or unexplained chronic cough, also abbreviated as RCC. And numbers have shown that up to 27.9% of people with chronic cough, for example, across France, Germany, Italy, and Spain have refractory chronic cough, which will be today's topic. There are many guidelines on this topic, and so I would like to point out a couple and some information from these guidelines. So depending in which country you are, you should look up your country's guidelines from pulmonology mostly, and look, for example, at the assessment algorithm. So we should all have a look at the various causes of chronic cough, because it's very complex, and to see at which point, so what has been already checked or what should be considered moving forward. And so this is just an example from Australia, but like I said, different countries have their own guidelines on this, and these are really nice visual algorithms. And in all of them, and I'm highlighting a few guidelines here, there is a really strong recommendation for RCC, so the refractory chronic cough or unexplained chronic cough, to involve a speech therapy. So this is an example for Australia. Then this is an example for the UK, paper from 2026 or letter that they emphasize the importance of a multidisciplinary input, especially including speech and language therapy. And then also an example here from Germany, the new 2025 cough guidelines of the German Respiratory Society, also very strong recommendation to involve a speech therapy. So yeah, look up your country's guidelines or find one that you would refer to. And what I've also found helpful in the clinic is to find, to look up patient guidelines. So for Europe, as an example, there is a patient guidelines in lay language, and obviously a shorter version than the long guideline talking about diagnosing and treating chronic cough in adults. And for example, there's also a German translation. So since this is complex information and is often also confusing for patients why they have this refractory chronic cough, this can be additional information that they can take home and look at and ask questions as they come up. So what about the pathophysiology of refractory chronic cough? So the pathophysiology points to a cough hypersensitivity syndrome. So that is a term that has been used lately, and there are three ways to think about it or that come together. So for example, hypertusia. So basically there is a stimulus that would make you cough, but your response to it is over the top, essentially. So there's a much larger response than that you should have or could have. And then allotusia, so it's basically a cough in relation to breathing in cold air or breathing in smell, or even like speaking a lot and having to cough. And then there's also laryngeal paresthesia. So what precipitates it? So often, certainly also not always, but often the beginning is an upper respiratory infection or a protracted upper respiratory infection. And then the hypothesis is that the cold is over, but the cough reflex is sensitized and persists, like again with a chronic cough, persists longer than 8 weeks, and for many patients even for years that come to the clinic. What about speech therapy? So I want to introduce this term. So in many papers you will see this description: behavioral cough suppression therapy. And at this point, actually, there are a few papers that nicely describe the ingredients of cough suppression therapy. And as you can tell, it's a behavioral therapy. So we're talking about the refractory chronic cough. And so obviously there should be also medical involvement to check other causes. But then there's this behavioral component, and we are the providers essentially for this behavioral type of therapy. Then another way to look at it, equally important, actually, we have to merge these two terms or approaches. I would also like to encourage everyone to think about the refractory chronic cough as a functional disorder, so functional cough. And this has been described and explained in the guidelines for the management of functional communication disorders, swallowing cough, and related disorders. So from this paper on the functional disorders, would like to actually quote that the group from this paper suggests that conceptualizing laryngeal hypersensitivity syndrome as a functional disorder is appropriate. So, like I said before, with the cough hypersensitivity syndrome, the cough persists, although the infection, for example, is over. So it's a persistence as a result actually of reversible changes in function. So that's key with functional disorders, that you can reverse that mechanism. And also this aspect of aberrant, involuntarily learned behaviors. And that's basically a key then for the therapy approach. So it's happening involuntarily, but we want to make this more conscious again. So what are the ingredients of therapy? So step one is explaining the mechanism of the symptom. So what is a cough reflex, that there are voluntary and involuntary components, that there is a self-perpetuating nature if you keep coughing. I always use this analogy of an itch. So if you have an itch, you would like to scratch, but the more you scratch, the more it's itching. So this is a good example of the self-perpetuating nature. There are obviously negative side effects also for the vocal folds, if you keep coughing with high pressure and high impact for the vocal folds. And pointing out, like, if you don't have a cold, if you're not sick, the cough is of no benefit. And a key really is, I really found this last point really key in my experience with patients, working on the acceptance that one can develop voluntary control over the cough, because that seems so foreign to patients at first, but it's key to success. Then there are a bunch of strategies to suppress the cough, reduce sensitivity to cough reflex, regain voluntary control. It's a lot of management, in the sense of figuring out what are actually the triggers, and also the early triggers, to really think hard about that, and maybe to do a diary, and to go deep as far as the triggers. Then noticing signs to urge, like what does it feel like, noticing, developing an awareness for throat tightness, which is often a problem. So key is essentially, the goal is to prevent, then to be able to stop it in the tracks, and interrupt basically the cough or the urge to cough. There are a bunch of laryngeal control techniques, like using pursed lip breathing, then also substitution techniques, like having an urge to cough and to do an effortful swallow instead, so replacing the urge to cough with something else, or to take a sip of water, to suck on lozenges, chewing gum, and also to replace it with humming instead, a different stimulus to the vocal folds that is actually wouldn't necessarily or should not cause coughing. So there's a treatment hierarchy, and it's also exposure therapy, so that so step by step, depending on the patient, you start to expose them to triggers as well. So the goal is to bring coughing, but also breathing, that's also an important component, under voluntary control, and to give them more security. So vocal hygiene education or vocal care, hydration is a topic. So it's nice that we just had this great introduction about hydration. I would like to point out one aspect of this. I do find that a lot of people are mouth breathers. And so working with them on nasal breathing that warms up the air, that filters the air, is actually also a really important part of the cough therapy. At the psychological level, what is important is keeping them motivated. I mean, obviously they come to you with a really also with extremely high expectations, but it's not necessarily a quick fix. So keeping them motivated, helping them to establish self-efficacy that they can get this cough under control, so locus of control, reducing hypervigilance, which is an important topic because they're so hyper aware often of their sensations in their vocal tract. So bringing that down, calming them down is important. And so so there is, for example, this paper that came out recently, the effect of attentional manipulation on cough reflex sensitivity. That's an important topic and also goes hand in hand with research in the functional domain on functional neurological disorders, that dual task paradigms, so basically doing tasks that diverting attention away from the cough should be useful and are useful, actually, anecdotally. And many patients, that's a nice thing, have an aha moment that they feel, oh, I didn't have to cough. If I wait a second, this urge to cough actually sometimes even goes away. Or if I'm playing chess, I don't have to cough. Just thinking through it, it's really important psychologically. Like I said, many of these papers on behavioral cough suppression therapy, you can also look at this one, for example. There's a nice table also on the various steps to include. I want to highlight this one, which is included, box breathing. This is indeed something I do in many cases and with many people with different kinds of functional disorders. So essentially a breathing meditation. Box breathing is counting, inhaling for 4 counts, waiting for 4 counts, then exhaling for 4 counts, and then waiting again for 4 counts. So it's a little box. There are different versions of breathing meditations that I use. Another one is inhaling for 4 counts, waiting for 7 counts, and then exhaling for 11 counts. And breathing is really the foundation of well-being, and getting the mind off, getting into a breathing meditation can indeed be very helpful. Basically, also in the context of anxiety, because think about this population. They have this urge to cough. They feel they cannot go anywhere. And so giving them back a sense of calm is important. So lastly, I would like to point out an outcome measure for refractory chronic cough. How can you measure this? As an example, there's a Leicester cough questionnaire. There are various translations also. This is, for example, a questionnaire or other questionnaires, depending on what is available to you, that can be used to track outcomes. So lastly, I would like to say it's again, like, it's not a quick fix. There needs to be patience. You really need to work, often also work with this population for a little longer, but it's worth it. Thank you very much.
Thank you, Maria. Again, very insightful talk. And sometimes, we see patients who have complaints of chronic cough and with no clue on how to work with them. So really nice to hear about the practical suggestions as well as the resources available in the literature that we can try with our patients. So thank you so much. Okay, so last but not least, let me introduce Anna, our last speaker for the webinar today. Anna?
Hi, thanks so much for having me to talk today. So I'm going to talk about silent reflux, loud consequences, and look at this relationship between laryngopharyngeal reflux and the voice. I've included some additional learning outcomes for today's talk. These are probably likely to be somewhat ambitious, given that I have around 15 minutes or so to talk, but let's see what we can do. So laryngopharyngeal reflux. Now, it's likely that all of us here know that this term, commonly abbreviated to LPR, refers to a reflux of the gastric contents proximal to the upper esophageal sphincter, and that it leads to symptoms including cough, dysphonia, globus, and sore throat. So a range of different terms have been used historically. Some are preferred by different specialties or in different areas geographically, and some of these may be used interchangeably today. So let's start by picturing a patient that we may all be familiar with. If a patient presented to you with hoarseness, vocal fatigue, throat clearing, and globus symptoms, and on laryngeal examination had normal vocal fold movement, interarytenoid edema, and mild posterior laryngeal edema, for example, how confident would you be that reflux was the explanation? We would probably all have slightly different views on this. It may be that it is laryngopharyngeal reflux. It may also be that they have muscle tension dysphonia, hypersensitivity, allergy, or it's plausible, even perhaps likely, that it's actually a combination of these factors. And so a seemingly simple question of does this patient have reflux is not really the sufficient question to ask if we are going to do our patient's symptoms justice. So when the interest in laryngopharyngeal reflux as a diagnosis grew around 30, 35, even 40 years ago, this traditional model of impact considered that the reflux material led to laryngeal inflammation, in turn leading to voice and other throat symptoms such as throat clearing and globus. But since that time, vast amounts of time and funding have gone into understanding that this diagnosis, they've gone into understanding the diagnosis, into improving diagnostic testing, into treating reflux pharmacologically, and into advising and educating patients. So interest peaked in around the early 2000s, but in the last 10 years or so, concerns around diagnostic uncertainty and skepticism about how freely patients are given this kind of label have grown, and the complexity of the interplay between diagnosis and symptoms has gained much more attention. So today I'm going to spend a little bit more time exploring some of the differing perspectives and debates around the term. We'll look at some of them in turn. So LPR as an under-recognized cause for voice and throat symptoms was a dominant model for many years, based on a lot of the Kaufman's early work. And the core principles here focus on the fact that the larynx is not the esophagus. There is a different response to reflux in the throat compared to the esophagus. And this is really where that concept of silent reflux grew. These patients didn't typically have heartburn or typical gastro symptoms. A surge in understanding regarding the enzyme pepsin, which is produced in the stomach, led to a big shift away from acid reflux and to a greater importance on the identification of pepsin in the upper airway, as that being evidence that laryngopharyngeal reflux was occurring. And this led to growing interest in pepsin-based diagnostics and consumables like alkaline water. Over time, there's been a more prolific acceptance that LPR is not a homogeneous disease and that various phenotypes are likely to exist. This explains why a one-size-fits-all approach is inadequate, both in terms of diagnostics, but also in terms of the treatment protocols. And greater understanding in research and clinicians of phenotypes helps us to improve and personalize our interventions. An important argument put forward by those who've studied professional voice users extensively, such as Sattelov and others, is that laryngologists and voice clinicians see the impact of reflux before our colleagues in gastroenterology do. So subtle changes in voice and performance ability develop long before any obvious disease develops. And this matters because some of the diagnostic tests and measures and metrics used in gastroenterology may underestimate clinically meaningful reflux in a professional voice user population. Now, our friends and colleagues in gastroenterology are undeniably absolute experts in gastroesophageal reflux disease identification and management. And the gastroenterology perspective has significantly informed our understanding. But some of the views on the frequency of events and diagnostic techniques may have altered focus. And there's also a highly relevant argument put forward by the field that the symptoms of LPR are non-specific and can all occur in other disorders. A warning to us that a diagnosis of LPR should not just be handed out without due consideration of potential other causes of the patient's symptoms. Some of the skepticism around the proliferation of LPR as a cause for voice and throat symptoms comes from looking at response to treatment. So a simplistic argument would be that if reflux causes these symptoms, then treating reflux should consistently improve them. But sadly, we know this is not the case. A surge in prescribing bi-daily PPI treatments by ENT, and sometimes even as a first-line treatment by GPs for dysphonia, is now changing. Studies are increasingly highlighting the contraindications of PPIs, and studies such as the TOPITS trial, randomized control trial, considering lansoprazole versus placebo, have shown bi-daily PPI to be less effective in placebo in patients with throat symptoms. Furthermore, we know from studies that there's very poor correlation between a patient's symptom, their reporting of that symptom, and objective testing. So diagnosis becomes increasingly cloudy when we also study laryngoscopy findings. We might typically look for reports of erythema, edema, posterior commissure hypertrophy. These are all well cited as potential signs of LPR and are included in diagnostic tools such as the reflux finding scale. However, we know both that these findings can occur in asymptomatic individuals and that these findings may represent laryngeal irritation from another cause. Focus has been on trying to identify biomarkers for LPR. However, there are continued uncertainties. For example, we know that the presence of pepsin in saliva must have come from the stomach, but debate continues around the magnitude of clinical importance on this. So where does a speech and language therapist, speech and language pathologist, I'll use SLT for now, fit into this debate? I am sure we have all seen patients who fit into one of these two camps. So a patient may present with very convincing reflux symptoms, voice change, throat clearing, vocal fatigue, but have inconclusive findings of LPR when tested. Conversely, though, a patient may present with substantial reflux on testing, significant changes on laryngeal examination, but surprisingly little voice disturbance or symptom reporting. So if both of these scenarios are seen in our clinical practice, it leads us to ask, well, what mediates the relationship between reflux and the voice? And it can help to consider some of the potential mechanisms at play. For example, there may be mucosal injury from direct exposure to stomach contents. The effect of this exposure may lead to changes in the composition and flexibility of the tissue. And patients may experience sensory effects, which in themselves can cause further phonotrauma. This can lead to behavioral changes, altering the laryngeal gesture, both at rest and on phonation. And so if we start to consider the impact as potentially coming from a range of angles, we can start to see that any given patient may be variably impacted by the following. And in turn, this means that that patient's experience is going to be individual. So a newer model may have some additional steps involved. So here we acknowledge the additional factors that we've discussed, the processes involved, and then importantly, this draws us back to the discussion around phenotypes. It may be that we have different groups of patients here. Some symptoms may be reflux-driven, some may be reflux-associated, and others may appear independent of evidence of reflux. So why does this matter to those of us working in voice? Well, taking a broader view of the potential impacts of reflux on the voice matters for speech and language therapists working in voice because it helps us to consider more diligently, what is it that we are treating? Are we treating tissue injury, muscle tension, throat clearing, hypervigilance, reduced vocal confidence, or maladaptive vocal behaviours. And of course, the likelihood is that our intervention will require us to tackle all of these things in different patients, plus many more. So there's a huge overlap between other conditions and diagnoses. No one size fits all, and our interventions will cover a range of approaches. Importantly, like all of our interventions, it requires the patient to be actively involved and is heavily dependent on behaviour change. It's also likely that for many patients, we'll join them partway through their journey. They may well have trialled PPIs, diet changes, had a number of medical investigations, or tried remedies passed on by friends, families, and increasingly artificial intelligence. So we therefore have a role to play more in treating the consequences of the reflux than the reflux itself. So thinking about where the future is with LPR and voice, there's a growing recognition that LPR may not simply be an acid problem. We're thinking about hypersensitivity, neurogenic mechanisms, inflammatory responses, and a whole host of behavioural and environmental contributors. We need to have more precise diagnosis, moving away from symptom diagnosis only or empirical PPI trialling and prescribing. We need to think about personalised medicine, phenotyping patients into different subgroups, and especially multidisciplinary care. But this is where there's a really important role for us because there's a greater understanding about the role for behavioural and SLT-led management, particularly in cough suppression. Maria was just talking about voice care, reducing phonotrauma, and even respiratory retraining. So in summary, yes, reflux can affect the voice. Voice symptoms alone do not diagnose reflux. Those persistent symptoms don't necessarily correlate with persistent reflux. We know that accurate diagnoses continue to be really clinically challenging and that there are downsides and flaws, limitations to many of them. Behavioural adaptations may become the dominant problem by the time that we've seen the patient, so we're treating the consequences of the problem. And we play a very important role in identifying some of those reflux-related voice symptoms, supporting vocal health, and contributing to multidisciplinary management. So the key takeaways are silent reflux may be quiet in the esophagus, but loud in our voice clinics. Not every hoarse voice is caused by reflux, but I think reflux should still remain part of the conversation. And really the challenge for us is not simply identifying reflux, but it's understanding that complex interaction between the larynx, behaviour, sensitivity, and voice use. There are a few key publications which I think are useful to have a look at, some references, and thank you very much for having me speak.
Thank you, Anna. Thank you, Anna, for the talk and your remark on thinking the LPR, need to beyond acid alone is refreshing, as well as the importance. You particularly, I'm glad that you raised the importance of the personalized medicine in voice care, which is very important in this aspect. So thank you so much for all the 3 talks, and your talks really fit perfectly to the webinar topic and nicely complement each other as well. So thank you so much. And now let's move on to the panel discussion. I can see there are a number of questions typed in the chat box. Let me find out.
Would you like me to read them out one by one?
Yes, that would be great. Thank you, Vanessa.
Okay. So the first one is for Preeti. It says, you mentioned that low humidity increases evaporative loss from the vocal fold surface. In your view, is the dominant problem reduced airway surface liquid, increased mucous viscosity, or changes in epithelial transport? And which of these is most clinically relevant for voice users? Also, what happens to local food flow when dehydrated?
Okay, so thank you for that question. I would say my answer is all those mechanisms. So when you are exposed to low humidity, there is going to be some evaporation of the surface fluid, which in turn is going to increase the viscous properties of the mucus, which is part of that surface liquid. So it's all the above. Now, I think the second question pertained to blood flow, and we have done some studies that have shown that that blood flow actually also reduces with systemic dehydration, not surface dehydration, which is no surprise because, of course, blood flow is the primary source of hydration to the vocal folds. So my thought there would be, given that exposure to low humidity can actually cause evaporation of the surface fluid, the best clinical recommendation, if that is suspect as a trigger for susceptibility to voice in terms of chronic cough or reflux symptoms, is to actually encourage use of a humidifier so that the inhaled air can be more humid and reduce that evaporation.
So the next question is also for Preeti. And it says, has your work looked into the impact of steam inhalations? I'm seeing lots of interest now in nebulizing cold for vocal health rather than steaming, in brackets hot. Do you have any thoughts on the different impact of these?
So that's an interesting question. So the role of like a thermal stimulus in the upper airway has long been studied, but again, there's no scientific consensus. So, of course, as we all know, the upper airway is lined by chemosensory receptors that are going to be triggered preferentially by cold or warm stimulus. So I'll go back to a common thread that I have sensed across our talks, and Estelle, you pointed out too, is this notion of personalized medicine. So when it comes to, what works best, I recommend that our patients try a few different things, and whatever works for them is the best strategy for them. So for some, it might be a cold stimulus, and for others, it might be a warm stimulus. Now, fundamentally, given the size of the airway, it's unlikely that the cold air gets warmed up enough before it reaches the vocal folds, right? So again, the goal is if a patient is more responsive to a particular type of chemosensory stimulus, that's what they should use. Thank you.
So now this question is for Maria. For graded exposure and exposure therapy, what type of exposure that is used, and does the strength of the cough correlated with identification of functional coughing disorder, or is it more reliant to patients' reports?
Okay, so cough severity and correlation with functional disorders. I cannot say that I see a particular correlation. And again, like many patients are complex, so they might also have a lung disease or other issues going on. So there certainly might be cases that I would consider more purely functional with a severe cough, but again, like there might be also more complex cases with comorbidities that have an equally severe cough, or so that can really vary, I think, across functional or more comorbid cases. And then the first part of the question, remind me again, was?
It was about exposure therapy. What type of exposure?
Yeah. So typical triggers are can be weather related, like cold air, humid air, smells, perfumes, chemicals. Obviously, like with some of these, avoidance is part of it, like avoiding strong chemicals is probably generally a good thing. But with some other triggers, like like weather related, or it can also be food in some cases. It's always a question of graded exposure, right? You start small. I mean, it can also be a hot coffee, like changing the temperature of food, reducing how spicy food is. Really, like we said, we're going back actually to personalized medicine, to tailor it to the patient, because it needs to work, it needs to fit their lifestyle, and to see what can they change and what small changes can they make that already make a big difference. So I would say that is key.
So another question for Maria. As box breathing can be part of the treatment for RCC, does it mean that sometimes RCC can be caused by anxiety, or anxiety contributes to the persistence of RCC?
Yes, I did not go into this aspect. I mean, I touched on it a little bit, but I do think, and I do see that clinically, that we can also look at this topic from a completely psychological perspective, from the psychiatric perspective, that depression or anxiety disorders or combinations of various psychiatric disorders can also lead to this urge to cough, and can be anxiety related. And it's also right. It can be primary. It can also be secondary. That with the more you cough, the more you become anxious in social situations. That it's actually becomes a vicious cycle as well. So we can touch on these, like I said, we can touch on some of these topics within voice therapy, but with some cases, we always have to consider, should there be a psychological assessment, a psychiatric assessment, and should there be psychotherapy as an adjunct?
So I have two questions for Anna now. The first is if alkaline water helps, and the second is how frequently do you involve GI physiology for pH impedance to support reflex diagnosis management?
Okay, so the first question, thank you, about alkaline water. So Jamie Kaufman has done some studies on this. The idea behind the alkaline water is that when you have pepsin in the throat that has been refluxed, the pepsin will remain active in the throat. And so even if the pepsin comes up in a reflux event, as soon as somebody has something acidic to eat or drink, that pepsin will become activated. So the idea behind the alkaline water is to deactivate that pepsin. So there's been some studies that suggest it may be useful. Certainly in our clinic, patients who have tried it feel it's useful. I have to say there's been a few studies suggesting, well, a few kind of case reports looking at the importance of advising patients not to use alkaline drops that are then added to water, because when alkaline hits the skin, it can actually cause burning. So very much thinking about, if you are suggesting it, suggest using the pre-made water, alkaline water. But yeah, so the idea is around the idea of it denaturing that pepsin, which doesn't happen otherwise. It just sits there and remains active. The next question was around how often do we refer to gastro for pH testing or impedance testing, or both, perhaps?
Impedance, pH impedance.
Impedance testing.
Impedance to support reflex diagnosis management.
Yeah, so I think it really depends on the patient and how they present. We don't refer a huge number of patients, but then some patients come from gastro having had that. We tend to complete with all of our patients the GETS questionnaire, the Glasgow, Edinburgh throat symptoms, and that often flags up patients who you might be more interested in referring to gastroenterology. we do refer on for manometry. We've got long waiting lists. So I think what we tend to do is try and treat the patients as best we can whilst they're waiting for further tests, but obviously refer on as we need to. I think it's a kind of case-by-case basis. But it adds really important information. I think the other thing we do perhaps more now than referring straight on is to do transnasal esophagoscopies. So we can look at the top of the esophagus. I say we, not me, the consultant. So we can look and see if the patient, for example, has other things that might be contributing to their symptoms, like a gastric inlet patch or something like that in the esophagus.
Next question is for Preeti. Many voice patients report deterioration of vocal clarity with increased environmental humidity. What is your opinion on this matter?
Oh, that's interesting. I don't have a good answer to that. I imagine it has something to do with just someone's comfort and sensory kind of response to a very humid environment. It might have to do with fluid flow and kind of the mechanical questions and how airflow transpires and what happens to acoustics with high humidity. I often get the question, why does my voice sound much better when I'm in the shower? So it's a similar type of question. I don't know the answer. It's something I'll ruminate on, but it could be an interesting study to see in a high humidity environment why clarity might be affected. Yeah.
Another question for Preeti. What would be your recommendations for patients who are and need to stay on medications with dryness effects?
So I would say it depends on the type of medication. If the medication is like a diuretic that's causing more systemic water loss, then it is to balance water intake. If it's a drying medication because it's like an antihistamine or something for an upper airway, then I think a humidifier can be quite helpful. So the recommendation for systemic versus superficial hydration will really depend on the type of modality for the dryness from the medicine.
Moving on to Maria now. Have you come across chronic throat clearing rather than chronic cough? I've seen it in several patients and I'm convinced the underlying causes and treatments are the same as cough.
Yes, I have come across cases like that, but I would say definitely more cases with chronic cough, but I would concur that the treatment approach would be similar. So yes, definitely.
And again, Maria, I would like to ask Maria a question. Is BCST suitable for kids with chronic cough?
Yes, that's a good question. Actually, I only work with the adult population, so maybe some of the others can chime in. I mean, you always have to adapt therapy to the pediatric population a bit to keep them engaged and to make it interesting and child-friendly. But I would assume that you can definitely also translate that. I'm not into that particular literature, but I hope there is some.
Moving on to Anna. Do you think that LPR can be expressed influenced by temperature effects? Example, heat from vocalizing and or drinks?
I mean, my initial thought would be that this probably relates to sensitivity within the larynx, which may have been impacted by reflux and laryngopharyngeal reflux. So one of the mechanisms of being exposed to the stomach contents is that the throat is often then hypersensitive. And at that point, very much so, we often see that anything like temperature changes, talking, laughing, all these things are then going to influence it. So yeah, I think that's a really common complaint by our patients that come in and say that temperature and temperature effects will cause them to be more symptomatic.
Going back to Preeti, so there is the first question. Is there any value in asking patients to monitor the color of their urine and get it close to clear or pale yellow to ensure good hydration?
So, urine is interesting because the color is not really governed by the amount of water intake, but diet and other medications. So, from a scientific lens, it's not the best indicator of hydration. That said, assuming there are no underlying conditions, there are no significant dietary restrictions that may impact the color, sure. There's no downside, but I would caution anyone to use that as a sole determinant of the hydration state that someone is in.
Okay. Preeti again. There's been a lot of talk in the singing community recently about steaming not being as effective as a nebulizer as the mist is finer, and if using an isotonic 0.9% saline, the vocal cords absorb the moisture faster than large steam droplets. What are your thoughts on this? Again, patient preference.
Yes, so always governed by patient preference and what they feel they respond more to. It's not surprising that isotonic saline would feel better than water because isotonic saline is more like the composition of the liquid that's lining the airway. And with any dehydration, that liquid layer is what's getting depleted. So, isotonic saline, understandably being more similar to the biology of fluids in the body, might make patients feel better than nebulizing water or some other stimulus.
Okay, so I have one last question here. I think we have covered them all. Which says, I have had cases of people who fast with no water intake for 3 days and minimal water intake for well over a month or more with no impact on the voice. May there be a scientific explanation for this?
Yeah, so that's the interesting thing, right? And we've discussed this across the 3 talks that there are different phenotypes of how you respond to a perturbation or a challenge. And a lot of that is determined by the underlying biology. So in a lot of healthy young adults who, have water restriction for a confined period of time, the body is really clever and it's going to adapt to the dehydration and is going to reach a new level of homeostasis. So it's not surprising that someone doesn't have voice problems. On the other hand, one shouldn't be surprised that the same challenge can result or manifest in a very different symptomatology with some patients because of the underlying biology. So again, this is one of the reasons when we think about approaching and what an optimal treatment is, there really is no standardized treatment. It has to be tailored to the individual's presentation and what they report.
So I think we have answered all the questions. Just one comment before I pass on to Estella. I wish, on behalf of President Tamer Abu El Saad, I wish to thank the speakers for their contributions today and for all the participants for attending. Thank you.
Thank you. Thank you, Vanessa. Thank you, Thomas, for the lovely, encouraging words for this webinar. So I'm sure that all of you would agree that this webinar is so engaging and definitely has triggered lots of great interest from the audience, as seen by the many questions raised by the audience. Just shortly before we close this webinar, perhaps I introduce each speaker to just name a very quick bring-home message as the takeaway for our audience. So who would like, Maria, you would like to start first?
Sure, I can start. I would like to reiterate with the cough therapy that that patients, so being patient is important in this type of therapy, but at the same time to work quickly toward an aha moment, that they have a sense of success and realize this is a therapy approach that is possible, that will help me.
That's lovely. Thank you. Preeti and Anna, any take-home message? Preeti.
So I can go next. I would say, you know, from the lens of vocal fold hydration, it is not the cause, it is not a treatment for voice disorders. But I think because there is a robust data that suggests that it can support vocal health, it's really important to think with each patient and tailor expectations for hydration for their specific vocal needs. Thanks.
Thank you. Thank you, Preeti. And Anna?
I think I would come back to the idea of the personalized medicine aspect, the no one size fits all. And the fact that regardless of what we are telling patients or suggesting to them, nothing is going to change unless we have got the patient on board and we are working with them together to make a goal. All of these things we're talking about, whether it's drinking fluids, coughing, or controlling reflux, depend on behaviour change. So we need to make sure that the patient has the capability to do what we're asking them to, the opportunity to fit that into their life, and the motivation by understanding what they're going to get from it, why this is going to help if they engage with therapy.
Thank you. Thank you so much. So thank you all again. And for audience, please do keep this momentum go on and share with your peers, with your friends on you know, the content, the topic, the talks that you listened at the webinar today. And again, this webinar is being recorded. It will be uploaded to the IALP YouTube channel. So please do come back and go through the webinar again. And also keep an eye on all upcoming events and activities of the IALP and the Voice Committee. One way to get in touch with us is to follow the IALP's LinkedIn page and also the YouTube channel. Now, could Vanessa help me to send the survey of this webinar on the chat in the chat box? So for audience, we need your help. So there is a feedback form about the webinars today that Vanessa is going to upload to the chat box. Please do fill in. We love to hear your feedback. We love to hear your likes, your great talks, these comments, and let us know. So as we bring to today's discussion, the panel discussion to a close, please join me to thank our incredible speakers. Again, Dr. Preeti Sivasanka, Dr. Maria Dietrich, and Dr. Anna White for sharing their experience and expertise and their fourfold engagement. So please join me in giving us our speakers another round of applause, and I'll see you again at our next event. Thank you so much.